Welcome to another episode of Notable Perspectives. I'm your host, Dr. Muthu Alagappan, and today we're joined by Dr. Susan Turney. Dr. Susan Turney is the CEO of Marshfield Clinic Health System. Prior to becoming the CEO of Marshfield, Dr. Turney was the president and CEO of the Medical Group Management Association, the leading association for medical group practice administrators and executives from 2011 to 2014. Before that, she was CEO and executive vice president of the Wisconsin Medical Society, and through her leadership, the Medical Society founded the Wisconsin Statewide Health Information Network to improve individual and community health, promote patient-centered healthcare, and advance the use of information technology to improve healthcare quality and efficiency. Dr. Turney, a native of Wisconsin, was a practicing physician of internal medicine at the Marshfield Clinic. Dr. Turney, thank you for joining us today.
Well, thank you. I'm pleased to be with you today.
So I'd love to start from the beginning. You're a physician. What got you first interested in healthcare and becoming a doctor?
You know, it's interesting. I have always been interested in science and always interested in helping people since the time I was a small child. And I even remarked when I was in kindergarten to the teacher at that time that I wanted to be a doctor when I grew up. If you fast forward, I later, while in practice, ended up taking care of that teacher. So life does come full circle, but I think her saying to me that girls could not be physicians was a great motivator and obviously proved to be successful for me because I ended up practicing for nearly 25 years.
And first of all, that's a just phenomenal story of how the world does come full circle. How would you describe how you kind of transitioned from practicing medicine into administrative and leadership positions and eventually becoming the CEO of the health system you work at today?
You know, it's interesting because I think there's something so special about taking care of patients. And like I said, I took care of patients or was involved in direct patient care for almost 25 years. However, as I spent more and more time working with people on an individual basis, I realized collectively that there were a lot of things that needed to be done from a macro or from a systemic level in healthcare. And so as a result of that, I started spending some time trying to bridge the gap really between the practice of medicine and the business of medicine. And when I started that journey, there were really parallel tracks for care and for the business. But I really wanted to put my knowledge and experience to good use and really make healthcare just a little bit better for our patients and for our communities.
I've always been really interested in whether there are certain skills you learn from practicing medicine that then translate into leading health systems or leadership positions in general. Are there certain skills or experiences from your sort of practicing days that you've then drawn on a lot in your leadership positions?
I think there are a number of things for me personally that have really piqued my interest in healthcare and continued my commitment to healthcare. Mostly, it has to do with my deep passion around rural healthcare. I know that the patients and the people that live in our communities tend to be a little bit older, sicker, and poorer than patients in people in other parts of the country. Many of the people that live in the communities that we serve as an organization are my friends and family. So I know the challenges that occur in rural healthcare. I know that some of them seem a little insurmountable at times when we think about the headwinds that are facing us. But I really believe that it's a commitment to the patients in the communities and part of my mission, as well as part of the mission of the organization.
When it comes to technology and digital transformation, some point out that rural communities are less likely to engage with technology and digital approaches to care than individuals in non-rural communities. Have you found that to be true in your health system?
You know, we entered the digital world 30 years ago when we actually started our telehealth program. And the reason we started the program was related to the challenges that we face in our communities. People live a long distance from their care providers. Of course, again, with people in our communities tending to be older, sicker, and poorer than our state and national average. And the challenge is just transportation in order to come for a visit. Oftentimes having to have family members take time off work to drive them. So we have a lot of unique issues, right, with the population that we serve. So we had to be innovative, and we had to think about ways that we could best serve our patients. Of course, care delivery accelerated a little faster than the payment mechanisms or payment schemes for covering digital care, remote services, telehealth. However, we knew that we had to provide that option for our patients where we could, if that was the only way that they could seek the care that they needed. So it's been a journey, and the adoption rate of all technology, I think, accelerated. Using that word again during the pandemic, because there weren't many choices for patients at that point in time. But I think the opportunity for us presented, and we took advantage of it and have continued to grow in multiple ways where we can better serve our patients through technological means.
So impressive to hear that this was a journey you all started on 30 years ago. Are there specific techniques you've used to engage the population digitally, marketing strategies, patient education? How have you been successful in getting this population to adopt technology as a medium of sort of care navigation?
Mm-hmm. I think that there are a couple of reasons why people have accepted this modality. And again, partly is the geography. We serve 1.5 million people, but we serve those patients across 65,000 square miles. And our largest community is just over 50,000 people. Otherwise, most of the places that we actually have established facilities are in communities of less than 2,000. So again, it's the geography as well as the economic pressures that our patients feel. We know that for many of our patients, for them to come for a visit, again, oftentimes they will have to have a family member transport them. That family member might not have paid time off. There's a lot of small businesses in our communities, and they oftentimes would have to come, take the time to bring their loved ones for care and would not get paid for being absent. And oftentimes they would even have their children in tow, and which is not a fun thing to be schlepping kids through a facility all day while a parent or grandparent is getting care. So I think a big part of it is just people adapting to changes in their environment and understanding that we can make it more convenient for them for a lot of the care that they need, particularly if it's chronic care management, as an example. So we're very pleased to be able to do this with our patients. And of course, with the pandemic, we found that there were oftentimes no other options for care. And the biggest challenge at that point is we still have about 10 to 15% at that point of our service area that was not covered by broadband. So we've worked with our communities to bring broadband into those service areas so that patients can actually seek care. Like most places in the country, many people have mobile phones, and that really provided access to care that might not otherwise be available.
Well, what I'm hearing is during the pandemic, it may have been due to necessity that this adoption happened. But outside of the pandemic, it's been due to the convenience that technology has offered to seek care, to manage chronic conditions, and much more. When people talk about digital technology, digital transformation, there's often a split view on whether it's helpful or harmful to rural communities. So some people say that it actually further entrenches and reinforces some of the digital divide and can actually make health disparities, even more pronounced. Whereas other people say technology can actually be a great equalizer and provide multilingual support and access to care for folks that are otherwise marginalized. I have a guess, but where on that spectrum of helpful versus harmful do you tend to stand?
That's actually a very interesting question. And I would say, technology isn't going away, right? We do know that it allows us better ways of providing care for our patients. And I don't see that slowing down anytime soon as advancements occur. So I think there might not be a complete equal distribution or complete equity, but we are trying to do everything that we can in healthcare to what I would say, as you said, shrink that divide that does exist. So our organization is constantly working with our communities, as I mentioned, and our elected leaders as we had to expand rural broadband. A small amount of money goes a long way for people to be able to access care. And we also have the opportunity to really teach our patients, our families, our communities about the capabilities that do exist. As you said, what are you doing? Well, we talk to our patients. We have had volunteers from our high schools, kids go into the homes and help our patients with maneuvering the nuances of trying to be on the computer. So I think it's really critical that we understand that this is our way of life, and it is something that we have to embrace in order to really meet our mission.
That's fantastic, and I thank you for sharing that. I like to think about technology as a mechanism, as sort of an agent of change. And so, when you think about the problems that are facing your patient population, your community now, if you had a magic wand to sort of create a technology that could solve, those problems, which problem do you think needs the most attention, or what is the problem you'd want, that sort of magic wand focused on?
Well, I might need more than one thing to fix all the things that I would need to really provide accessible, very efficient, streamlined care across the entire continuum for our patients. I think the biggest thing is making all of this seamless. It seems very daunting at times to use the technology, and it also it's things that many people are not comfortable with. So if we can provide the information, the education, and create a streamlined process so that it's comfortable, it allows patients and families to be able to communicate with ease, and it results in the outcomes that we want, because we don't want any type of technology or modality to really be a barrier in any way, whether it's access or whether it's communication or whether it's the way we provide care. So I think that's really probably what's most important.
You mentioned one piece there around technology to improve communication for patients and their families. One thing, as a potential downside of technology we've seen is in cases with bidirectional chat or messaging where patients can message back and forth with providers. It's often very convenient for patients and families, but leads to a huge number of messages and sort of increased responsibility on the care team, which may or may not be contributing to higher levels of work stress and burnout. Have you seen that play out at Marshfield? And is that a concern of yours at all, that technology could maybe make the patient experience better, but at the detriment of the amount of work that staff now have to do?
That's a very good question. And I would say that, yes, the inbox can be tough to manage. So I think from a provider perspective, we need to figure out a way to optimize the resources that we have available to us in helping manage that patient care. Every question that comes to a physician or to an advanced practice clinician does not require the same level of expertise. And if we have the ability to triage some of those questions so that they're really dealing with the issues that only they can address, is extremely important. That doesn't solve all the problems, clearly. I'm chuckling a little bit because I was part of the sticky day, and I had sticky notes all over my desktop, all over my desk or door, when I would come back from making hospital rounds with people that needed my attention. So it isn't a new problem; it's just being managed differently. But the accessibility has definitely increased, and I think that's exciting. I'm glad that patients are engaged in their care. I'm glad that they're reaching out to their clinicians. I'm glad that they're seeking information that they believe will help them. So it's a tough one to manage, though. It really is. And I think when in our geography particularly, if people have to drive an hour or two, or there's 12 inches of snow on the ground and you have a sick child, you're going to turn to something that is convenient, which means there's going to be more back and forth through some sort of technology modality. So we just have to figure out how to manage it.
I love the perspective of the sticky notes and how the problem is it's maybe different in shape, but it's the same problem maybe we've had even before technology. It just looked a little different.
Yeah.
We've talked a bit about healthcare disparities, and I want to touch on healthcare equity as well. So, you are a founding member of the Carol Emmett Foundation's Equity Collaborative. Would love if you could tell us more about that and what inspired you to be a founding member of that organization.
It's I did not know Carol Emmett, but the people that have known her and have shared their experience with her makes me feel like I'm at least pretty familiar with the wonderful work that she did in promoting health equity. And I think particularly right now, I'm very, very passionate about supporting and about elevating fellow women in leadership. We know that the vast majority of people that work in healthcare are women. We know that there are proportionately less women in leadership than men. And I think for me, being able to reinforce the importance of having diversity at the table, being able to show the importance of achieving equity for both our administrative staff, our physician leaders, as well as equity in the way we provide services is really, it's just essential. It's not even just important, it's essential. So I do think that having an opportunity to be part of this foundation has really allowed us to build a very strong network of women who support each other. And also, I think having these women leaders in our organization promotes change, not just within our organization, but actually throughout the industry.
Are there lessons you've learned from your own journey into leadership, or advice you'd have to women who are kind of hoping to take on those types of positions in terms of how to navigate their careers?
You know, you need a lot of grit. There's no question about it. But I think if you're driven by your passion and you care deeply about your purpose, which in my case is really taking care of our patients, families, and communities, that just gives such a great foundation for what you hope to achieve from a professional perspective. And as I think about all the simple things that we can do in our lives, I think our clinicians, our physicians, and other advanced practitioners, as well as the people that support them, do an excellent job in taking care of people when they show up on our doorstep. The problem is that's such a small part of their life. So for me, having a much more global understanding of what happens to people in their communities, what their needs are for education, transportation, healthy food, housing is extremely important. So I think just being embracing and inclusive and really understanding what drives the individual, but how you can make a difference in the communities that we do serve.
On the topic of healthcare equity as it relates to leadership and management, would love to talk a little bit about the future of work and how the workplace will perhaps transform in this, as a result of the pandemic and what we've seen over the last few years. One trend that has become very pronounced are the labor shortages across different service lines and roles. Uh, are you seeing that at Marshfield, and in what specific roles or areas are you feeling the labor shortage to be most pressing, and how has that sort of presented itself over the last few months?
Well, it sounds like I'm hanging the black crepe paper here, and that's not my intent. But rural healthcare was in crisis before the pandemic, and for a number of reasons. And one of those is the workforce. From research that has been done, we know that well over 90% of residents that complete their training want to provide care in communities of more than 50,000 people. Well, I mentioned a little bit about our geography. We cover 65,000 square miles, a little over 1.5 million patients, and we have a single community that's more than 50,000 people. So just the ability to recruit and retain and to keep the physicians engaged is a huge challenge for us. But it's not just physicians. It's all clinicians, it's technologists, it's the staff that supports the practice, as well as the administrative staff that we need to run the business of medicine. Wisconsin has been a little protected, I think, in this journey. Probably because of all the large multi-specialty clinics and hospital health systems that do exist within the state. However, we know from recent reports that although Wisconsin had no hospitals on the hospital closure list until a few years ago when there were 10, in the recent report, there were 24 hospitals that are at risk of shuttering. And those are hospitals within that we don't own, but work with in our communities. About 30% of people who live in Wisconsin and in Michigan live in our service area. And we know that oftentimes if we're not present in a community, there isn't going to be any other provider. So that is a huge, huge challenge, and probably the thing that I think about most when I get up in the morning, and probably the thing that keeps me up at night is workforce. There are a lot of other macroeconomic things that are happening in our country today, but that is a huge, huge challenge for us. And I would add that right now we over this weekend, at the end of last week and over the weekend, we had to reinstitute our incident command because our beds were full, and that across our 12 hospital system, including our NICU, our PICU, our adult beds. We had patients boarding in the emergency room. And part of the challenge is having adequate workforce to help us take care of people. And right now we're even having a challenge bringing in contracted staff. So that's not going to go away in the short term. I know as we look forward, there are things that we can do from an automation perspective that will help us. But all of that is not in place right now. So it's figuring out ways to put the patient first and to take care of all the patients that we can. But it's hugely challenging.
And it sounds like, very, very challenging across the country, perhaps especially in these rural areas. Seems to have been a problem, even pre-pandemic, especially for clinical roles, and now probably affecting all roles. How much of the labor shortage is pressure from outside industries raising wages, taking employees that used to work in healthcare in administrative roles, support roles, and now are moving into food service, Amazon? Are you seeing that shift out of healthcare just given the wage pressure?
There's huge wage pressure on in our industry right now. And we do want to make sure that we're treating our staff fairly and providing salaries that are commensurate with the market. Yet there are, we're a huge nonprofit organization, yet we have very thin margins as we operate. And we know that to do any across the board increase in salary has a huge amount of dollars attached to that. And right now, when healthcare systems are really struggling, there's less. Certainly, the market is not done very well. The acuity and the intensity of care that we're providing has gone up, and the need for staff to take care of the patients has also gone up dramatically. And I talked about contract labor that is extremely expensive for our organization. So I think if you put all this together, there isn't a simple answer as to how we can proceed as we go forward. the challenges are there, and I think we all have to manage the best we can. Just make sure whatever resources we need, we provide, and really knowing what our strengths are to really continue doing what we do best.
Yeah, I've thought about this problem myself a fair amount, both as a practicing clinician and at Notable. It's, I'm sure kept me up at night as well. Probably not as much as you, but, we've spent time thinking about it. And to me, it has always felt inevitable that we're going to have to leverage automation, like you said, digital workforces to help get more of the work done. It sounds like you're in agreement of that. What is the time frame in which you'd expect a health system like yours, to adopt automation in a way that really makes a dent into this problem?
There are so many ways that we've already adopted technology to really help us in managing patient care. And I mean, it's similar to what others are doing, obviously. When a patient is discharged from the hospital, we look at their risk and use the intelligence that we have to determine what resources they need when they're discharged in a much more sophisticated way than we've ever been able to do that in the past, which helps not only manage care better, but also hopefully provides the patient with a better outcome, better quality of life, and prevents an ER visit or another readmission. But there are other ways that we work on this regularly. 10 years ago, we didn't have the capabilities to manage heart failure patients in the way that we can manage them right now. And we know that the ability to have access to someone 24/7, to have regular check-ins digitally, to have someone monitoring and trending the patient care data can substantially reduce the number of emergency room visits, the number of admissions and readmissions for that patient population. But again, the goal is really to provide better patient care and to make sure that the patient is getting what they need and has that quality of life so that they can function without having to have acute care visits. So, there's a lot of technology in place already, yet it's going to continue. We're going to have to continue to look at what options are available and what we can do either on our own or with partners as we, again, sort of assess the resources they have and the strengths that we have and build it in a way that optimizes the efficiencies of the way we provide care, but also creates an opportunity for patients to do the best that they can.
Definitely. And you mentioned, a point there at the end of, choosing or deciding, is it something that we can do on our own, or do we need to partner with an organization on this capability? How do you make those determinations of when you want to solve a problem with technology? How do you decide if it's a problem you're going to try to tackle on your own versus look to the market at, vendors or partners that can help you solve it?
It's interesting because I mentioned our journey in telehealth has been 30 years, although we've had an electronic health record that was developed internally about 50 years ago. The scale of what's needed in the electronic health record and how it connects with many, many, many other tools that we need to use to optimize patient care has changed so dramatically that we are now in the middle of implementing a new electronic health record for our health system, which comes with a little pain, obviously. But we know that in order to, it's an ongoing assessment. I think less and less can be done internally, and more has to be done with our wonderful technology partners. It's time to implementation, it's the cost, it's the connectivity and the efficiencies that can be created. I know one of our former CFOs always said, every time I bring in more technology, people say it's going to be less people and we're going to save money. And he said, it always ends up being more people, and we don't always see the cost savings that we'd like to generate. So I think, it's sort of that this doesn't happen overnight. Overall, however, I think technology will help us provide better access and will streamline care and will create better outcome for our patient, but also result in some savings because of the way that we can do business more quickly, more efficiently. And at least that's my hope.
You mentioned it doesn't happen overnight. We often think about it as a journey that's not a straight line. There's certainly um, local sort of dips and inflections as you're sort of adopting technology, but the long-term trend, hopefully is very, very positive. When you're thinking about the partners that you like to work with, what are some of the characteristics of those partners that make them good partners to you? What are the intangible qualities of the team or of the partnership that make an organization feel like a good partner to Marshfield?
That's interesting. And I think for technology, it has to be based on who we serve. And of course, we serve patients, we serve families, we serve our communities. So I think if that passion exists within the company and it's part of the culture and the mission is to really enrich lives, that is extremely important to us. Now, it might sound a little lofty, but if we have a good relationship with the people that we partner with, and they're as committed as we are to advancing the work that we do, that human element is essential.
I love that. And sort of on that note, maybe we have time for one more question. So I'd like to leave, by asking you, what do you think the rural health system of the future will look like or should look like? What's your grand vision for where we should try to get to?
I'd like to think that we're part of that, of what it will look like in the future. I think being able to have a fully integrated health system where we offer the continuum of care, also having a health plan, which helps us innovate. To me, that is what rural healthcare needs to look like. We also have to, again, recognize the unique challenges that exist in rural healthcare. And I would say that not every health system is willing to make a commitment to rural communities. It's just as one example, we have many counties in our service area that have less than 2 people working for every Medicare beneficiary. In many more populated areas, large cities in particular, there are 6 or 7 people working for every Medicare beneficiary. So you can see that the trends that are happening in this country are going to happen all over, including areas that have a much deeper pool or population of commercial patients. We know how to do it. We've been able to not just survive, but really thrive in an environment where we have the economic challenges that I've described, yet we firmly believe that providing a high level of care as close to home as possible, leveraging the technology in the most efficient ways that we can, and really impacting care, not just in the buildings that we provide services, but outside of our walls in our communities where we're deeply embedded, will be what the healthcare system or the rural healthcare system of the future looks like.
Well, thank you for sharing that vision. This has been a pleasure, and thank you for joining us today, Dr. Turney.
Thank you very much.